Thanks, everyone. We are going to begin the third session of that morning, and I will let Bob do the chairman and the introduction. Thank you.
I guess it's not on.
I think you can hear you.
I'll just, it's on. Okay, I'm Bob Sheldon. Welcome to a session of World's Worst Arrhythmia Nightmares. Nightmares are dreams. I call dreams are not real, and we don't seem to have any arrhythmias in this session. So they are the world's worst nightmares. Before we get started, I'd like to present an award to the best real talk of this session. Everybody else is virtual. Congratulations, you win the award. Dr. Vidya Raj. So Vidya is our psychiatrist. She's the head of our Minds and Hearts Clinic, and she's our go-to person for problems mainly with ICDs and patients' responses to them and shocks, and some of it's really terrible. So please tell us how to fix it.
Good morning, everyone. Can you hear me okay? Great. It's a great pleasure to be here. Thank you to CHRS for inviting me to talk to you. I'm Dr. Raj. I'm an assistant professor of psychiatry and cardiac sciences at the University of Calgary, and I'm the director of the Hearts and Minds Clinic, which accepts referrals from cardiac sciences for patients who need psychiatric evaluation and potential treatment. It's a great pleasure to be here to talk to you about ICD shock syndrome. I'd like to take just a moment to make my respectful land acknowledgement, as seen on the slide, and also tell you, sadly, I have no disclosures to make. Yeah. So I know I'm speaking to a highly educated audience here who knows the value of an ICD, and I don't want to oversell that point, but they are amazing for most patients. There are many trials, including the AVID study and many others, that have shown that an ICD along with an antiarrhythmic medication is far superior in terms of reducing mortality in our arrhythmia patients compared with a drug alone. Most patients do really well with them. But I'm here to talk to you about the significant minority of patients that is actually growing that does not and develops an anxiety disorder. I'm sure you've seen this clinically because the prevalence of ICDs is increasing so much in our elderly population. You are, I'm sure, seeing more of the advent of this particular anxiety disorder that's unique to arrhythmia. So it started off by first noting that people who were shocked repeatedly seem to develop an anxiety disorder, simple observation. But it turns out there's kind of an amount to this. So 5 or more earmarks a patient for significantly increased risk of developing an anxiety disorder. And also another phenomenon, ICD, repeated shocks within a particular episode, 3 or more, is also associated with increased risk of developing this disorder. So studying this particular population in more detail, research has now shown that there are more factors that you can use to identify who's at risk of this. Patients will tend to be of younger age, more likely to be of female gender, will have limited sort of support network to start with, limited resources in life, and are more likely to be depressed even prior to having the ICD placed. There are a couple of other factors you may not have heard of. One is called type D personality, which is a tendency to feel negative emotion a lot, but keep your mouth shut about it. You keep the emotion in and don't talk much about it. And the final risk factor here is called high anxiety sensitivity. This is the kind of person who avoids doing things for fear of generating anxiety or anxiety-related symptoms. They just don't like to feel anxious at all. Symptoms you will see in clinical practice include all of the following: depression and anxiety, panic attacks, a fear of death. Sleep-related symptoms, insomnia, and then nightmares related to being shocked again. Another nice, unique symptom here, phantom shocks. This is when a patient says, I feel like I'm being shocked, but your data says they actually have not received an ICD discharge. Flashbacks are very vivid dreams in the daytime of having shocks again. And then you've got these more sort of muted withdrawal symptoms. I'm avoidant of life, I've withdrawn, I'm emotionally numb, and I'm feeling completely helpless and don't want to deal with this. Okay. So this new phenomenon has been termed shock anxiety or ICD shock syndrome in the literature. It's still very poorly defined. Patients can present with as sort of recurrent panic attacks. They can have adjustment symptoms, meaning anxiety symptoms related to the task of having to adjust their life around now having an ICD and all the necessary changes they have to make. And finally, the worst end of the spectrum is completely PTSD. This are anxiety symptoms in a triad of re-experiencing phenomena. They re-experience having a shock in some way. They're hypervigilant, and they avoid any stimuli that are associated with reminding them that they have had a shock. It can be really paralyzing for a lot of people and cause really prominent insomnia symptoms. So this is data in terms of the studies that have looked at this. They suggest that about 20% of patients will strictly meet criteria for PTSD at implantation. By about 12 months, this reduces. It goes to about 13%. But then latest data suggests there's this worrying trend that it seems to increase again after about 4 years. I don't know the reasons, but this is what the data says. This is really the only slide I actually want you to remember, which is it actually really matters in terms of outcomes, and it should matter to you because it means a bad outcome for your patient. The 5-year mortality with ICD shock syndrome is increased, and the hazard ratio is 3.2, which is really sobering, right? These people are more likely to die. They're more likely to have ICD storm. They will rate their quality of life, not surprisingly, as pretty bad, both across the physical and mental health realms. They are not likely to engage in much physical activity. They're too scared to do so, right? They're worried about being shocked again. And then here's the other kicker. Whatever you tell them to do, whatever medicines you ask them to take, they are 2 to 3 times less likely to take that as if they did not have ICD shock syndrome. My colleague at the University of East Carolina, Dr. Samuel Sears, who regularly comes to Calgary to talk about this topic, has created, validated, and made freely available a scale called the Florida Shock Anxiety Scale. Patients rate their symptoms across these 10 criteria as between 0, meaning I don't experience it at all, to 5, which is all the time, giving a score, if my math is correct, of 0 to 50. So the nice thing about this is not only does it rate how anxious a patient is in some way, it also gives advice as to what should be done. At 0 to 10, these patients are fairly mildly affected, and the recommendation is just monitor them to see, hopefully they don't get worse. If they score in the 21 to 30 realm, this is when you want to be spending a bit more time with that patient, educating them what it actually means to live with an ICD, how they navigate life, and particularly, they talk about this concept of the shock plan, where on paper you want this patient to have a plan. What am I going to do next time I have an ICD shock? Who am I going to call? What is my threshold to go to the hospital? And to actually, it really helps to discuss this with the care team. That can be really helpful. At 31 to 40, these are moderate symptoms, and you should be thinking of referring them to a psychotherapist at that point. 41 to 50 is pretty bad, right? Those patients, that's a very enriched population for PTSD. And for those patients, frequent psychotherapy, whatever is available, and you want to consider adding psychotropic medications. When I say you, it doesn't necessarily have to be you. This is family doctor or psychiatrist at that stage. There's good evidence for psychotherapy in this particular patient population. I just threw in one recent meta-analysis that shows that you can expect improved physical health quality of life measures and at least trend level improvement in mental health quality of life measures going through psychotherapy. Also, this interesting finding of less likely to have shocks in the 12-month follow-up period. Psychotherapy consists of two important elements. One is learning to live with your ICD, that education piece that we mentioned. All of the studies will have that in common. And the second thing is CBT, so changing someone's cognitive perceptions from, I have a ticking time bomb in my chest that can explode at any time and ruin my life and hurt me, to more along the lines of, this is my last wall of defense. If anything bad happens, it will protect me from dying and is simply an indicator that my arrhythmia team are going to help me for this not to happen again, to do something about this. So that concept actually has to change. Simplest slide, I have nothing to say about psychotropic medications. We have no studies in patients with ICD shock syndrome at this point. But we have lots of studies generally in patients with cardiac disease across the board. Just a brief synopsis in the favor of time here. SSRIs are safe in patients. I can at least tell you they won't kill them. Most of the trials have used sertraline or citalopram, two standard SSRIs. They will show that patients are as likely, if they have cardiac disease, to respond to these medications as anyone, even without cardiac disease. Escitalopram is preferred over citalopram these days because citalopram now has this black box warning for increased risk of QTc prolongation at high doses. Just a clinical fact there. Tricyclics and monoamine oxidase inhibitors not used. I don't know of anyone in this room who would probably have used a monoamine oxidase inhibitor. Am I correct? Like, we rarely use them. But they have a bunch of side effects, and tricyclics, of course, have that quinidine-like arrhythmic potential. So benzodiazepines get a really bad rap, but in cardiac patients, they're really safe. They don't really have arrhythmic potential unless anyone corrects me. They do help a lot very quickly in the most severe PTSD cases by bringing down anxiety and also treating that insomnia piece really quickly, quicker than an SSRI that takes about 2 to 4 weeks to really reach benefit. So I will use them in severe cases, but you don't want to ideally be using them long-term because you know the bad rap they have. They can cause sedation, they can have addiction and tolerance potential, and if you're elderly, they increase the risk of dementia and falls, which is not good. So I do bear that in mind too, but short-term, they can be really, really effective. So just in conclusion, the main take-home points I wanted to bring home were that ICD shock syndrome prevalence it's there, and it's going to increase because more and more people are having ICDs. It is associated with some bad outcomes, so poor quality of life, increased risk of non-adherence, low physical activity, more shocks, and above all, increased mortality. The Florida Shock Anxiety Scale is freely available and can be used by patients to rate the magnitude of the anxiety and to suggest an appropriate treatment approach. Data consistently supports psychotherapy, as mentioned. While there's no data for psychotropic medications in this particular population, there's good evidence that they are safe and effective in cardiac patients in general. And that's largely what I wanted to say. As you probably all know, this is the clinic that I run and how to refer patients in the Alberta region if needed. Thanks for your attention.
Thank you very much. Don't go away. We have 7 or 8 minutes for questions. Distinguished panelists.
Yes, so does anybody have a question? If not, I will ask Dr. Raj a question. In reading this literature, I'd come across the term normalized anxiety or fear. Is that still an accepted term, or does it fall into the mild portion of that Florida scale?
I'm not actually sure what you mean. What literature has talked about normalized anxiety?
Yeah, the same, patients who get shocks.
Yeah.
This has been published, and so the author of that group that looked at patients who have received heart failure said that some individuals have normalized anxiety and fear to any medical procedure, and especially ICD insertion. So how do we recognize a patient who is in that category, which is normalized fear or anxiety, and how do we alert ourselves so that we can refer them to you sooner than later?
So, this is a very lame answer. Apart from the data I know, I'm not quite sure. I mean, the term normalized anxiety, I'm having difficulties kind of understanding what they're trying to...
Me too. So
Well-
I'll send you the reference. I'll send you the article anyway.
Okay. I think, the concept definitely in mental health is that so you can have any level of symptoms. It's gray though. The question is, when does it become a problem? And we hand wave and say when it becomes functionally a problem to the patient or the people who care about them most. So they have functional problems, or their life is just so miserable that they need help. So there has to be an element that I can be anxious and have a panic attack, and I can think there's no problem. That's just me, and you can deal with it. You're not going to hospitalize me or do anything. But if it's recurrently causing me distress, or people around me distress, or I can't function, I can't get out of my house, I'm so anxious, then I'm going to come for treatment. I don't understand the normalized. Maybe it's just sort of like reactive anxiety. Just we're all going to have a bit of anxiety when dealing with things, but only really when it becomes pathological is an issue. And usually patients and their relatives will say something. That's my long hand-wavy answer.
Oh, I have a question. Rupi, there's a hand going up.
That was a great presentation. Just wondering how much of patients' anxieties are related to how well we talk to them initially about an ICD implant and what they could expect.
Yeah, that's a loaded question. There's always the push to get people through and to do your job as an arrhythmia attending, right? I do think there's value. If people know what's going on, it gives a little bit more of a sense of control. I know what to expect. If you look at the data, a big piece of what can be done isn't necessarily psychiatric. A lot of it is just reassurance, and this is what will happen to you. This is how to adjust your life successfully, and this is what to do when the worst happens, when you have a shock. That piece to me suggests that if people know more about what's coming, that probably is going to be helpful. I don't have data to support that, but I think knowledge is power, really, for a patient. Okay.
So, words matter, but only sort of. My sense is that society at large has become much more familiar with the term PTSD. And we know that its societal meaning has really become quite diffuse.
Yeah.
Right? So my question to you is, when you're seeing patients who we've sent to you, how much do you care about the diagnostic label PTSD, and how much, what are the things that you use in your practice, in your experience, to say, well, this is the intervention I need for this amount of disability, I need this for this amount of disability, and what are the markers that you practically use?
So they're multi-level, right? So there's my DSM-5, there's a scale that can be used, but above and beyond, it's this gray concept. It's like, how much does this bother me? What is it preventing me doing in my life? And sometimes I have to just clarify what the goals are. It might be that I am scared to exercise as much as I need to. How do I deal with that? Like I'm avoiding doing that, or I can't sleep. It depends on what symptom or what they're going for in terms of improvement.
So are you saying we should ask our patients what their priorities are?
At least I should, but yeah.
That'll slow us down a lot. Okay, time for one more question from the audience. You can ask a question, please.
Thank you for a lovely presentation. It's something that's really important, I think, that we don't really take the time to consider when we see patients, because we're worried about if they're on enough beta blocker and if they have their ACE inhibitors and all the other meds on board before we go ahead and offer the device. There are a number of risk calculators that we use to determine whether or not a primary prevention device is appropriate and worthwhile for a patient. And so is there a similar risk stratification screening tool that you would recommend that we use to screen for that, for the propensity or the risk of developing PTSD after the procedure? Is it something we should consider implementing routinely before we do the discussion with the patients? But should we be asking them the questions about anxiety and their general mood before we actually go ahead and offer them this device?
I can answer that on a really simple level. There is no data to support that, right? There isn't. And I think that you have to do what you have to do, right? If they need an ICD, you're going to offer that. How they deal with it afterwards isn't completely predictable. Humans aren't. And I think it's better to deal with it afterwards. I don't necessarily want a patient to go in worried, oh my gosh, I've been identified as having a high risk of this. I would rather you did your best, at least explain what's going on, or have your staff do it. To support the patient, and then just in follow-up appointments, at least ask the question, how are you doing with adjusting to life? And you can keep it that broad. And usually patients and or family members will say in no uncertain terms if they're not doing well. And then maybe you bring out the scale at that point. But that's how I would approach it at this point. I don't, at this point, have any recommendations that it's valuable to do that going into it, right? Because people will surprise you.
Okay, thank you very much. I'm afraid we'll have to move on. The next talk is a virtual one. Good. Connectology is working. And Dr. Chakrabarty is going to give us some insights on what do we do about driving after an ICD goes in.
Hi guys, can you hear me?
Yes, beautifully.
Okay, thanks. And can you see the screen of the presentation? Okay. Yeah, first, thanks for the invite. So initially, when I got the invite, I sort of got a bit apprehensive because I thought my secrets in my lab were getting out, like it's a nightmare session. But then I was told it's a dream presentation. So thanks, we've got a chance to convert the nightmare to the dream. Having said that, all nightmares are dreams, but not all dreams are nightmares. So we are going to talk about our little project, which is the dream study. Let me move this a little bit. Okay, get to the next slide. So first of all, I fully acknowledge we are very lucky to be presenting. I'm lucky to be presenting from British Columbia and the lands and waters where we work and play, and relevant to all of us. And also don't have any conflict of interest, nothing relevant to this project. Now, the background of this project was a little interaction when we were seeing a patient in CCU many years ago, and we were talking about driving restriction to a man who came from a relatively rural area. And he sort of said, like, you were asking me not to drive, but then what will I eat? I have to drive, I have to go to work, I have to take care of my family. Now, a little detail is the average Canadian drives around 15,000 kilometers per year. Interestingly, is the lowest in BC per person, 13,000 kilometers per year. And highest in, I think it's in Newfoundland, 18,000 kilometers. Nova Scotia comes second at 16K. Quebec is 14K. Now, so if we restrict driving to any one of us, for example, and say that, like, you can't drive for a day or a couple of days, that might be okay. But if we say that, we don't drive for 6 months, that can have significant toll in many ways. In fact, there are studies to show that if you prevent driving, especially in the elderly people who form a substantial part of our ICD cohort, there is social isolation, and it is related to other aspects like premature mortality, deteriorating health. They can't comply with medical care, depression, cognitive decline, and all the rest of it. Having said that, we are always very, very apprehensive that we should not be creating harm, and we are worried that if there's a significant arrhythmia, people can get syncope. And also the shock, as Vidya said in last talk, I mean, shock can create incapacitation during driving. And having said that, syncope is a very common thing. There's lots of nice papers, and having syncope during driving does not necessarily mean it's an arrhythmic syncope. And syncope during driving is not uncommon. All of us drive, and we know that driving gives us stress. And again, there are studies to show that driving itself can result in arrhythmia. And that can actually continue for the next hour or couple of hours, even after stopping driving. People can get STD changes, people can get arrhythmia. So it's a little more complex than what it appears to be. There are some reports of motor vehicle accidents due to arrhythmia itself, but actually, if you really look into it, not much. I mean, all of us look into ICDs, and ICDs get us good data. When was the last time any one of us have seen that someone has an arrhythmia during driving, and that has resulted in a motor vehicle accident? I mean, I've been here 15 years. I've seen only, I think, one case so far. And I'm sure all of us have seen, but these are few and far infrequent. Like every year we get about 7,000 ICDs implanted in Canada, and as people are living longer, the total burden of ICD care is increasing. At the moment, we have around 120,000 active ICDs in Canada. So everything, whatever we do, has a social impact. Now, this is a sort of a quick shot of this data is from Statistics Canada, I mean, from 2021, looking or showing how many fatalities we have every year, personal injuries in the drivers, and serious injuries and stuff. We were doing really very badly 20 years ago. And then various things have changed, road safety engineering, etc., etc. The last 2 years is a little bit skewed because of COVID-related things, social distancing, a lot of people working from home, etc., and that has impact in significant reduction of fatalities and injuries. But with things opening up, this may be going up and again. We will look to the data. Now, so we traditionally restrict driving after ICDs. The last guidelines which came out was actually 20 years ago from the Canadian Cardiovascular Society, and it, as all of us know, it says 1 month after a primary prevention defibrillator and 6 months after a secondary prevention defibrillator. And it does affect patients and caregivers in several ways, as we discussed, but also it has medical and legal implications, especially for people who are commercial drivers, or all of us have to take difficult decisions every year about asking someone not to drive, or then they have to go to disability or try to do something else. So that is, we'll come into it a bit later. Now, having said that, though, Vidya talked about the inappropriate, the PTSD side of things. But in my mind, one of the best studies in ICD care came out with Arthur Moss's Made It Right study, which showed that we can prevent inappropriate shocks significantly, and all of us have adopted this over the last few years. And also the current improvement in the heart failure horizon, the inappropriate and appropriate therapies for defibrillators are actually significantly less than what it was before. So, I have a question for Vidya in retrospect. Like, are you guys seeing more or less cases of inappropriate therapy requiring PTA and resulting in PTSD? But we can address that later. Now, this is the main sort of framework of why we do things. This came out from, it has got a Canadian background, but I could not find the logic to it. But this has been adopted by most countries. Basically, what it says is that the risk of harm, we need to mitigate harm, and the acceptable risk of harm is death or injury in 5 in 100,000. And I don't have a reference for it, but maybe I haven't looked enough. But this is derived in this sort of a complex formula. It says that what's the total duration of driving that you're doing. Then it factors into the vehicle type. Like if you're a commercial heavy truck driver, then it's 1. But if you're a standard size passenger car, it's 0.28. What's the risk of incapacitation? It is taken as 0.01. And I don't know where that number came from. And then also the probability of injury or accident after incapacitation, that's 2% or 0.02 for all drivers. So in this, what it said is like if you're a private driver, you will spend 4% of your time every day for driving. And at least in British Columbia, I'm not very sure that people can make like half an hour of commute every day for work. Definitely it is more. I'm very sure it's also similar in other provinces. But for the commercial drivers, they say driving is 6 hours per day on an average. Now, so we then decided to look into this because guidelines were 20 years old. New therapies that come in, we had Made It Right come out. And the credit actually goes to Chris Chung, who is in Toronto now. He came up with the name, the DREAM, and he's always very good in doing this. And Chris Steinberg and everyone else did a lot of work on this. So we have 2 projects, and third one is in the pipeline. So this DREAM ICD is for primary prevention defibrillators, and we included about 450 patients. Included transvenous devices, right? CRT, D, and ICD, 2 centers. DREAM ICD-2 is for secondary prevention devices. It is from 3 centers and included about 800 people. So we've got data on 1,200 people, but this data is contemporary data. The ICD settings are the new settings, Made It Right settings, or derivatives of Made It Right settings. And this is based on also most of these people had optimal heart failure treatment. Now, what we found is, well, I'll go through the DREAM ICD-1, which came out in CGC. Before we do that, though, you see on the right-hand side of the screen, there's the Made It Right program therapy. As all of us know, it was a Boston scientific study. Basically, there was a conventional arm and a high rate and a delayed therapy arm. And in follow-up, they showed the cumulative probability of the first occurrence of inappropriate therapy significantly reduced when you're using a high rate or delayed therapy strategy, right? Now, we compared that with our cohort, and we found that the DREAM in our cohorts, any appropriate therapy was again, and as you can see, in most of these parameters, they were significantly less, even compared to the Made It Right. So if you're really adherent to medical therapy and you're doing programming and everything, so you are probably getting a little bit more benefit than the Made It Right data. That's in DREAM 1.
Shanta, can you hear me? I'm Girish.
Yeah.
You are out of time, so 2 minutes you have to summarize because the next speaker is going to come on.
Okay, sure.
Because you're till 11:10.
Okay, so this is the DREAM 2 again. You see that this is showing the same thing when you compare to the ADVANCE 3 trials, significant reduction in even the secondary prevention therapies. So I won't do that. That's the DREAM SICD. So basically, maybe I'll go to the path forward is, I think the time is right now for new CCS guidelines on this. From what we have found in our work is if you take in the harm criteria, even 1 week after implantation of primary prevention defibrillator seems to be very appropriate. For secondary prevention, 3 months seems to be very appropriate. And SICD should be at par with transvenous ICDs. Now, future directions, I think we need to, at some point, open up some dialogue regarding restrictions for commercial drivers. And we have to think about, like, is that formula really relevant? Like, we've got self-driving cars coming out. We've got smaller cars coming out. And, you know, what's the interaction between defibrillators and electrical cars? There's some data regarding pacemakers, but not about defibrillators. But the future is exciting, and I hope you know, our trainees will take these projects forward. So yeah, thanks for your attention, and yeah, I'll be very happy to take some questions.
Thank you very much.
Thanks, Krish.
We can, so we're kind of over time here, and we started a bit late, so we won't have time for questions. I just want to have 2 quick comments here. The first is that at the CCS, I think it's on Thursday afternoon, the new guidelines will be shown, right? So it took a while to get through them all, but there are new guidelines. They're a little more evidence-based than the old ones. The second point is, where did 0.005% come from? Because there are 2 of us here that actually go back to about the time of the inflation of the universe. Dr. Green and I, we are your cultural legacy. And that number was from the 80s for the risk of sudden incapacitation in a truck driver post-MI who could exercise 4 Mets on a treadmill or something. It was something nebulous like that, because they were the only data. We got tons of data now from international registries, US, UK, here, that said that we grossly underestimated societal tolerance for carnage. And so 0.005% is not what society will tolerate. It's probably around 0.1%. I mean, it's really, society tolerates carnage. If they were serious about preventing carnage, every man and woman under 45 would be forbidden from driving, and every man and woman over 50 would be forbidden from driving. So if you want, we can talk about this later on, but be sure you're at the CCS. There's a guideline session. I think it's Thursday morning or afternoon. Okay, next speaker. Thank you very much. Next speaker, Dr. Skanavaka, going to tell us some more about cardioneuroablation. Sorry for keeping you waiting, but take us through the latest status in neuroablation. We can see you and we can see your slides.
Can you hear me?
And we can hear you.
Okay, thank you. So at first, it's a great honor to take part of this.
Maurizio, if you go down, if you drag your cursor right down to the bottom, and then go down to the left-hand side, there's a little slide thing all the way down to the bottom, all the way over to the left. Keep going left, just to the left of the word normal. Hit that.
Like this?
There you go. Okay, there you go.
Thank you very much. So at first, I'd like to thank you for the invitation. It's a great pleasure to participate in the Canadian Heart Rhythm Society Congress. It's a great pleasure. And mainly to talk about something that emerged many years ago in Brazil, the cardioneuroablation for vasovagal syncope. So why cardioneuroablation has become a little bit more known now, and why people are interested? Because it's a very intense procedure for some to avoid that young patients like in general, normal patients with vasovagal syncope, but some of these patients, they have a very symptomatic episodes of syncope, like these patients, a 30 years old male with convulsive syncope. Most of these patients, when they have this diagnosis, they receive a pacemaker. But cardioneuro ablation can avoid that patient receive a pacemaker for the rest of his life. Another situation is this kind of situation. They are not common in clinically, but to have being more and more this kind of patients, normal patients with long pause, sometimes during the night, but a long pause like this patient, 11 seconds during the night. So this patient had received for 3 other doctors pacemaker implantation, despite he was asymptomatic. So it was a case for also for cardioneuro ablation to avoid a pacemaker. How does it started? How was the beginning of this? How did the idea came up? So in my impression, it was a serendipity finding. If you remember, when we started making ablation of atrial fibrillation in beginning of 2000, there were many strategies for AFib ablation. And one of them was to make some autonomic modifications, vagal modification, denervation, because we had many evidence of vagal action can induce and maintain atrial fibrillation. So at that time, different groups around the world tried to make some work on this. One of the first was Paponi, people from Oklahoma City using high frequency stimulation, using the model prepared for Dr. Sharlag to stimulate the ganglionate peroxide described by Dr. Armour. So using this strategy associated to pulmonary vein isolation, they showed that it would be a better strategy. Here in Brazil, Dr. José Carlos Pachon used what he described as a nest electrograms to locate areas in the left atrial, sometimes the right atrial, where there was a fragmentation in the normal tissue, not a scar, but there are many activations at the same place. So suggesting that area could be something that could maintain atrial fibrillation. Ourselves, we work on this idea using high frequency stimulation on the epicardial, endocardial, trying to make exclusively vagal denervation without too much atrial ablation. Other groups work with anatomic approach on the endocardial ablation on these areas, and sometimes in the left atrial, both atrials, or even just in the right atrial. So it was in the beginning of the 2000, and after these observations, it was not so clear the effect of vagal denervation for atrial fibrillation ablation. In fact, pulmonary vein isolation was the most important effect. But what all this works they have a similarity was that despite a different approach for ablation on that areas, at the end of the procedure, patients presented the heart rate elevated and the variability, heart rate variability index, they were depressed. So it was very common in all of these studies. What this was also interesting that one before 2003, Dr. Michel Saguer's group had just published that some patients, when they had sinus pause or sinus node dysfunction apparently, or bradycardia tachycardia syndrome, when they underwent to catheter ablation for atrial fibrillation, the heart rate increased, and the patient didn't need it to implant a pacemaker. So they supposed at that time that there are some kind of reverse remodeling of the sinus node. They didn't think about the autonomic nervous system at that time. So that's, I think, the great idea of Pachon was to put together these observations and to use that results were obtaining during the atrial fibrillation ablation on the autonomic nervous system, this kind of modulation to treat some patients with autonomic disease, like a vasovagal syncope, and patients with hypertony, vagal hypertony with high AV block degrees. So he published in 2005 5 patients with vasovagal syncope with cardioinhibitory manifestation, and 7 patients with advanced AV block, which was published in the Europace 2005. And I don't know why, but there was not too much repercussion during some years. I think the first group to try to reproduce this observation was our group, also in Brazil. And because I think we did this case in 2007, 1 year after that publication. It was a very important case because they're a very young girl, just 15 years old, but with many episodes of vasovagal syncope refractory to non-pharmacological and pharmacological maneuvers. And that patient was referred for our institution to implant a pacemaker. So at that time, we discussed with the parents and suggest to try to make some kind of modulation on the vagal modulation before to implant the pacemaker. They accepted. It was a very interesting observation. As we had experience before with ablation and atrial fibrillation, trying to make the denervation, we noticed that the sinus node increased the heart rate, and if he accelerates the conduction when ablated in the septum, mainly in the left side of the septum, and sometimes in the right. So in this, as a young girl, we decided to select the areas with high frequency stimulation, with these areas with red signals. We locate in the septum, and did just 6 delivered posts. We delivered just 6 RF posts. It was very intense because we could abolish the reflex. It's before ablation, stimulating that place, and after ablation, we cannot reproduce the vagal reflex. And the index modulated for vagal action was all depressed.
Dr. Scanabach, we have 2 or 3 minutes left.
Okay. Sorry, because I received it at the time it was 20 minutes, but I can jump some.
Mauricio, you can go on till 10:50. Go ahead. Yeah.
Okay. I'm sorry. And here, when we followed the patient during the first month, we can note the heart rate was increased here, and the heart rate variability was depressed. Well, we were a little bit worried when they followed the patient almost 1 year after, because the heart rate was decreased. But you can see that the tooth test was completely normal, abolished without reflex, but in the heart rate variability was also maintained. After 6 years, patients completely asymptomatic, just sometimes with dizziness without syncope. We can see before ablation and after ablation a depression of the vagal tonus, maintained a long time. So that was our first observation. When we follow our next patient along with the years, we didn't have too many patients because the patients are very well selected for these procedures. You see that we just published now 24 patients with at least 2 years of follow-up, and the result for freedom of syncope is very high for patients with cardio-inhibitory. But patient AV block, we had some recurrence. You can see here, we have 4 recurrence, 3 patients with AV block, and 1 with sinus node dysfunction. And all of them just in the first year of the follow-up. Looking at the heart rate variability along the time, there is a recovery after 6 months, 12 months, but it maintained a little bit depressed during the long time. So there is not a complete denervation, but just attenuation. What's important to observe the collateral effects of this case, we have 2 patients with sinus tachycardia maintained 4 years and 5 years in 2 of these patients. They need to receive beta blockers and to control the heart rate to be less symptomatic. And more recently, we had 2 patients with occlusion of the sinus node artery during the procedure. Both cases were women, more than 50 years. And we suppose that maybe the aorta was a little bit angled. You see here, regular case, a young patient. You can see the format of the right atrium. And the case is a little bit flat. The aorta is pressing the right atrium. You can see the angle here. And this is the case. And sometimes I think it is push the coronary to the area of the superior vena cava. So the contact of the catheter is closer, and maybe many pulses in that area can provoke this. So it's something you have to be aware about that. Another thing everybody has some concern is about the protection of the vagal gives against ischemia and ventricular fibrillation. It's a new report from a group of California. They did in pigs. They promote a cardioneuroablation, demonstrating histologically the area, and they demonstrate the pigs were completely denervated. And after 6 weeks, they promoted occlusion of the coronary artery. And they could demonstrate that patients under vagal denervation, they have a very high incidence of ventricular fibrillation comparing to control. So that was an observation in a good phase that suggesting that the vagal denervation could increase in some part the risk of this patient. But if we see our patient, we make atrial fibrillation ablation, we do the same. So we demonstrate this many years ago when we compare the patients undergoing just for vagal denervation, focal vagal denervation, and those with pulmonary vein isolation without looking for the ganglia. Both patients, they had the same type of vagal denervation. So when we do atrial fibrillation ablation, we do a vagal denervation. So our patients undergoing to atrial fibrillation also would have this risk. So we have 20 years of atrial fibrillation, and I don't know about this kind of risk until now. So I jump a little bit about because of the time we have some difficulties. Still, we have already some meta-analysis showing that the procedure is effective around 20 and 90% of patients. We have now randomized study comparing ablation versus clinical treatment. showing that ablation is superior, but we don't have still a comparison with a shunt procedure. So, and we have also some difficulties to know how to make. Every group works in different way, like ablating all the atria, or just the septal, or just the right side. So there are some doubts about how to do this procedure. That's why I think there are some doubts about the physicians regarding to put this procedure in the guidelines. So I think this is one of the studies. I think there are many randomized studies going on at this time. This is in our place. We just started now in September. We have already included 3 patients. So to compare a shunt group with right atrial ablation and right and left atrial ablation. So in conclusion, RF in different areas of the atria related to GP locations, many at septal target promotes sinus node and AV vagal denervation. Those autonomic changes potentially promote clinical benefit in patients with vasovagal syncope and functional bradycardia. Late autonomic evaluation suggests partial recovery of heart rate variability indices without change in the clinical outcome. Randomized clinical controlled trials are needed to confirm its effectiveness and to evaluate the methods to precisely locate the targets for ablation and how extensive it can be done. Thank you for your attention.
Okay, thank you for that excellent overview. Let's start with the panelists and then the audience.
Yeah. Thank you for that excellent talk, Dr. Skanawaka. I don't know whether you remember it, but I did my first epicardial ablation under your guidance in 2003, and that takes a segue. I have also Carlos Murillo here, who is a co-chair, who was also with us and invited you over to Hamilton way back in 2004. So Carlos, this is a field that you know very well, so why don't you ask him the first question, and then we'll ask the audience.
Yeah, thanks, Grisha. It's a pleasure to be here from Madrid. So, Mauricio, it's a great study, and I think we all have the question that, when you put all these Kaplan-Meier curves, looks like once you do cardioneural ablation, nobody ever has syncope. Now, that's way too good to be true. So, what do you think really is the real recurrence rate in patients with cardiac addition? Because there's other groups that are actually promoting cardioneural ablation in mixed types, and also even in vasodepressor syncope, which from my perspective doesn't make a lot of sense. So what do you think is the real deal here? And the other question is, should we be comparing cardioneural ablation against CLS pacing in patients over 50 years?
Thank you, Carlos, for the questions. And when we did the first procedure, a patient had a very clear asystolic syncope during the tilt table test, and the patient had many traumatic syncopes. So the cardioinhibitory reaction was an important physiopathologic cause of the syncope. So when we did the first case, we are prepared to abolish the asystole, but we expect that patient presented some hypotension, and we prepared the family, or maybe we avoid the pacemaker because the patient maybe we won't have the pulse, but maybe she will need some treatment for vasodilatation. And some we prepared, but it was amazing that patient didn't need any other medicines. I didn't understand well why what occurred, but it was we start thinking about that. Along the time, this patient and the other patient we had sometimes they have some kind of dizziness or pre-syncope, not a syncope, sudden syncope. So I think the procedure is pretty similar to pacemaker. The pacemaker is the same. If you just put the pacemaker, you can abolish the pulse, but sometimes patient has a hypotension. So sometimes this patient, they need some other support to prevent this kind of manifestation. So if we select very well patient, selected patient with long pauses or asystoles, I think the procedure will be very good. If you put patients with vasodilation during the reflex, mainly with this, I think maybe it won't work too much. That's what perspective. Second.
Thanks. Yeah, no, I just want to make another question before other people can ask stuff. I always have a hard time trying to figure out which are these patients that you call functional sinus node dysfunction and functional AV block. How do you identify those patients?
It's amazing. When I saw the first time, I could understand why. Because the patient had suddenly, not just during the night, but during the day, a sudden block, AV block, 2 to 1 or very high, and the PP is the same. Why? How can I understand that? The sinus node seems to be normal, but the AV node, and when we investigated the patient, electrophysiological study was okay, exercise testing accelerates normally, and when we give atropine, removed. So it's a vagal reaction, but seems to be a vagal reaction exclusively in the AV node. It's like a differential action. It seems that the innervation is different, is exclusive in some patients. Some patients, we have the both innervation from the superior inferior ganglia to both nodes, sinus node and the node. But for other patients, they're completely separated. Seems that the sinus node has exclusively innervation, and the AV node also. And in some patients, they have this innervation with hypertony. When you make a denervation, the inferior part of the septum, you can correct this. I think some people say about the adenosine sensitivity. I don't understand very well the adenosine sensitivity. My experience suggests that it seems more selective vagal action for the AV node, because you can change when the ablate at that area.
I was wondering,
why not just give them theophylline?
Oh yeah, can be. You can use, but the problem is to use continually. I don't know if it's comfortable for the patient. A long time use. It's amazing because when you think about this, you are not involved with the procedure because it seems to be something very aggressive, but it's not. And it's like an ablation of WPW. You make something and it change completely. It's for patients, it's much better. Don't need to take drugs, medicine, and in the area to ablate is not so huge in the risk. I think little by little, I think we'll do it more. So I think we have to have these studies, randomized studies, demonstrated the efficacy, the safety. But I think it's a very interesting procedure.
Anybody from the audience has a question for Dr. Skanavaca? If not, I would like to also ask Dr. Sheldon to ask Dr. Skanavaca questions about what his outcomes are in his randomized trial and how he reached that, because I think you're most knowledgeable about that.
The outcomes, we are seeing the recurrence of clinically syncopes and pre-syncopes, quality of life, and the minimum follow-up is 2 years. And we always would like to understand a little bit what happened with the tilt table test. Some works have suggest that when we abolish the sinus node action, vagal action, you can change the tilt for more vasodepression. So we are interested to understand a little bit how this kind of changes. And we are trying to take some information of this trial about where to ablate and how much we need to ablate. We select the patients for the right side, the left side, and we use vagal stimulation to decide if a patient needs to improve it, to increase the number of pulses or the areas or not. The idea is to make the minimum necessary to promote the change.
Yeah, so you've touched on several of the factors that we really need to address at some point. I'd like to ask you a couple of fun questions and then one about outcomes. So the first fun question, so the ganglion, so I've actually looked into this. You can look at different species that have ganglionated plexi, and these things go back several hundred million years. Not only that, but as species evolve, there seems to be selective pressure to keep them and to make them more complicated. So why do we have ganglionated plexi, and how comfortable are you in ablating 300 million years of evolution in people who otherwise just faint? There goes my whole career, by the way, just faint.
Yes, no, I understand. My wife, Murilo, knows very well. Always said that, oh, people think that it's just vasovagal syndrome. It's nothing. It's that you don't die about that. But the quality of life of these people is very, very bad. Psychologically, is very important. When patients left the syncope, and even if they don't need to take medicine or put a pacemaker, or is something brilliant for them. They feel very, very, very happy. But the anatomy, and I think there are something missing. I agree with you, because sometimes I always did some, not a point like I showed in that young lady, but in patients normally I do a little bit higher number, larger of the ablations, trying, because there, when you cut, you'll see the specimen, you see there is a fat. There is a fat between the right atrium. In this fat, I think the ganglia was there. So the idea is to extend the lesion to avoid a recuperation of the ganglia. So, but many people, ourselves, we already documented this. Sometimes it's just one pulse, you ablate and everything changes. So since that you are ablating, I interpreted that like we are ablating a nerve, not the ganglia, completely ganglia. So if you take a point, the nerve is going to the sinus node, you denervate. So in many cases, you can do that. But we don't know is how long does it maintain. If you cut the nerve, maybe you have an immediate result, but late result is not so good. So that's why we always try to ablate a little bit more the area, septal area, to avoid complete reinnervation. But I think there are anatomic information missing. I think we have to improve this.
Okay, second fun question, because it actually bears directly on what you just said. When I looked at the just in one of the slides that you showed heart rate variability frequency plots, and you showed that the high frequency stuff, right, breathing, that's gone. And your numerical measures, RMS, STP, and N50, it's all the same stuff. That's breathing. The thing is, though, that the one around 0.1 hertz was still there, and that is some kind of baroreceptor mediated heart rate response to a blood pressure fluctuation. So what that says is actually there is preservation of the vagus on the sinus node. So what do you think? This is a completely open question. Are you ablating afferent nerves or efferent nerves, or is there something else in the ganglionated plexi that you happen to hit when you cluster bomb it, and that's the important thing, and it might not even be vagal?
I really don't know. I think we did most of the observations were, like I said before, was serendipity, because we are doing AFib ablation. And we noticed that when we are doing a pulmonary vein isolation, we obtain the same observation. We have the same. So when we do cardioneural ablation, we ablate much less than we do atrial fibrillation. So I think if there are some concern about the risk, long time, and loss of heart rate variability, the same concern should be maintained for atrial fibrillation ablation patients, because we do the same. So the problem is young patients, they are healthy than the patients we have atrial fibrillation and undergoing to atrial fibrillation ablation. So, but I think it's true. I think there is a need for basic studies, because I don't know why. It's a very rich area for that. There are not too many studies, because there are many things that could be done to clarify a little bit more what can be done with safety for this patient.
Okay, third question, just some practical advice, because lots of people are interested in doing randomized trials of this, right? So what do you think is the best early surrogate marker, either in the lab or within a week, say? What's the best surrogate marker for the procedure worked as a procedure? And what do you think is the best clinical marker, and when, for a clinical trial with clinical outcomes?
Good question. When we started doing this procedure, our observation was the heart rate, because when the ablate the septal area, mainly when the superior part, the superior vena cava and the right superior vein, there is an increase in the heart rate. Just after the first pulse, when we repeat the second, the third pulse, you don't see any more any change. And when you give atropine, there is nothing changed. The heart rate is the same as you completely denervated the patient. So that was the end point. We used it in the past. Passion, José Carlos Passon suggested that using external stimulation of the vagus could be a more effective. So I didn't notice a difference, because all the patients when we do the atropine, and at the end they are completely blocked. But for one kind of the situation, I think it's very good, the external stimulation, because the fails we had were for patients with AV block, because sometimes these ablations just the septum, we cannot reach the innervation for AV node. So stimulating the left vagus, sometimes we can identify patients, we need to extend a little bit more the ablation. So I think when we are looking for the AV node, I think the left stimulation is important. The problem is when we try to make the left stimulation, we cannot obtain this stimulation in at least 50% of patients. We have to find out how to put the catheter there, but sometimes it's very difficult to advance the lead to the foramen in the left side. And the right side is okay. Most of the patient can stimulate, but the left side is very difficult.
And the best long-term clinical outcome, what should we measure, and when should we measure it?
We are measuring with the symptoms. That's why the important for the patients. We are repeating the tilt table test, and we are doing heart rate variability in this, just to understand a little bit what happens with time.
Okay, thank you very much. I don't think I see any more questions. That's been great. Thank you very much. I'm afraid we got to move on. Our final talk, Dr. Schaller is going to talk about tricuspid regurgitation with leads. Topical problem indeed.
Hi, good afternoon. Just getting set up here.
Yeah.
Thank you so much for the invitation and opportunity. Greetings from Philadelphia. So this topic is relatively challenging. And how do you know if a lead is causing tricuspid regurgitation, and what can you do about it? And I'm not sure I know all the answers, but I'll certainly walk you through my thought process. Here are my disclosures, and one disclaimer is that when we get to intracardiac echo, views at Penn tend to be the mirror image of what you might be used to. So it tends to be easier to keep them the way that we're used to seeing them, and I try to label them appropriately. So there is no doubt that transvenous leads cause TR. There have been a number of studies that show that. The issue is how often do they cause TR and how severe is it? But it tends to be right around 20% of the time where you can identify that a patient increases their TR by at least 1 grade. But there are some studies that show no change or less change and argue that it just depends where you put these leads. And that does make sense. But the next question, of course, is can you figure out where to put them if you try? But in regard to leads and TR, there's no doubt. A recent study comparing tricuspid transvenous systems to the subcutaneous ICD clearly shows in an observational study, albeit that TR increases with transvenous leads. And we've looked into this a little bit to see if there's any procedural variable that can predict increased TR, including a prolapse technique versus the direct insertion technique, and that didn't show any ability to prognosticate, or whether the lead is in the apex or in the septum, and that failed as well. As well did varying degrees of lead slack. So there's very little that you can do apparently to deter increases in TR, at least in traditional labs. But interestingly, this gets pretty complicated because if a patient is going to have a CRT device implanted, we know that they develop much less TR, and that begs the point that TR really is multifactorial, and pacing can be quite detrimental as well. And some clinical scenarios are very straightforward, like if there's loops in this LV lead or in atrial leads, there's no doubt that we've seen these loops hold open the tricuspid valve, leading to severe TR that is temporally associated with the procedure. And it's not a surprise that if you pull these out quick enough, the TR goes away very quickly. Similarly, in this case where there was a frayed conductor left within the tricuspid valve, leading to torrential TR, removing that, although it was quite hard to do, led to much less TR on the follow-up echo. But when you're talking about the subtle forms of TR due to leads, you're usually looking at leads that are impinging one of the leaflets. They can also be entangled with the subvalvular apparatus. A little more on that later. That's a little harder to identify. Leads can certainly be perforated. I didn't really believe in this at at one point, but I've seen a number of examples of this now where leads actually through. This is one reason why I really like to prolapse these leads through. And then they could be chronically adhered, where they're not really doing anything to the lead at the moment. They're not even necessarily stuck, or they can be a little bit, but they fibrose over time, and that can lead to impingement of the leaflets. And if you look at operating room data, most of these leads that are causing TR are either impinged or adhered. It's much less likely to be entangled or perforated. And again, both of those can usually be mitigated with just simply prolapsing the lead through the annulus. If a lead is causing tricuspid regurgitation and is the primary reason, you really should have an eccentric jet that is tracking the lead. There's no reason why you shouldn't. If it's causing one of the leaflets to not coapt, then the TR jet should track the lead. And it should be relatively eccentric. But if you have a patient who just has annular dilatation that's causing TR, volume overload, it really should be concentric, and it should be right smack through the middle of the annulus. But of course, there's many different ways to have TR. And sometimes if a lead is adhered and causing primary TR for long enough, the annulus will dilate and you'll develop a secondary TR as well. So there are limitations to studying these patients with echo. But echo remains the gold standard to look at leads to the tricuspid valve. But if you simply use 2D TTE, you are limited in terms of identifying a lead that might be causing a problem. And it's striking how often you can't find an answer. And that's just because you simply can't image the region of the valve where the lead is going through. But the moment that you start using 3D TEE, and I didn't realize this was so much better than 2D TTE until preparing this, you really get to the point where you can identify or at least suggest what's going on with the lead and TR in upwards of 90% of cases. And these are some nice examples of 3D TE where the lead is restricting the septal leaflet, which is always here on the bottom. The lead is restricting the anterior leaflet over here. And this is a beautiful correlate in surgery where the lead is either through or completely adhered to the leaflets. Here we're restricting the posterior leaflet. And this is a lead that's safely in the commissure. Various studies have showed that it's the septal leaflet that is usually the one that is involved. And that's been our experience as well with ICE, which I'll talk to you more later. But you really want to see the lead right down, smack down the middle of the annulus, or in a commissure where it's not causing any problems. These leads are in fact down the middle. Here is a pre-op image of a patient with mild TR that is concentric and right in the middle of the annulus. And there's no difference in the post-op image, even though that jet is tracking the lead, it's down the middle and there's no difference in terms of change from baseline. Another one where the lead is right in the middle of, in a commissure of the annulus, and the mild TR doesn't change before or after the device. These are great places to put the leads if you can. Another example of a lead that's in the anterior commissure, and similarly in one of the commissures as well as here. So no temporal relationship, no increase in TR, certainly no temporal relationship to the procedure. And you can identify on echo that these leads are safely where they're supposed to be. When the lead is impinging, as it is here on the anterior leaflet, you tend to see more TR after the procedure, and you see a eccentric jet. I don't know if you can tell the vector of the jet, if that tells you which leaflet is being affected, but I'm sure some smart echocardiographers can do that. But sometimes they become somewhat complex and there's more than one jet. Here's a lead that's affecting the septal leaflet. Again, you see this by far the most, and there's significantly increased TR before and after the procedure. And here is a lead. It's tough to see on this 3D image, but it's affecting the posterior leaflet, leading to an eccentric jet. Here in this study from a couple of years ago, from Canada, using systematic 2D and 3D echo over 12 months, they were able to identify about 30% of patients will increase their degree of TR after the procedure. Here in these first two images, you see the lead nicely, either in the commissure, over here, or the lead in the center position. And when it comes to lead extraction, there's nothing I like more than seeing a lead dead center in the middle, flopping around of that valve. But you also can see the lead against the posterior leaflet right here. And this was seen, I think, second most in this study. Anterior leaflet, third most. You can see that the Doppler jet is tracking the lead here. And the septal leaflet, like it is in most studies, has been shown to be responsible for TR in the vast majority of these studies that have looked at it. You can also start to get a sense that this lead isn't moving freely in the annulus. You really want to see free movement, independent movement in the annulus. Whenever you see it fit, you start worrying that there's at least adherence and maybe impingement. And something that really bothers me during extraction cases is when the lead is attached to the subvalvular apparatus here, because there's very small and sensitive papillary muscles here that can lead to flail leaflets. So a septal leaflet or a leaflet in general can kind of take a joke every once in a while with extraction, but the second that you start involving the papillary muscles, you can really cause some damage with flail leaflets. Some more examples of a lead that just doesn't show any independent movement whatsoever, and it's closely associated with the leaflet. There's an eccentric jet of TR, and you can see that it is in fact likely adhere to the posterior leaflet. And finally, a similar case attached to the same leaflet with a very eccentric jet. That is just not a normal jet of TR to have in patients with typical right-sided heart failure, and you see it's surgically correlated to adherence to the posterior leaflet, and whether it's through or just impinging and adhered and fibrotic tissue has grown around it, I'm not sure. I'm not an echocardiographer, so I don't understand the views perfectly, but whenever you're using transesophageal echo, you do increase your ability to look at to identify lead adherence a little bit more than 2D. And I'm told that the transgastric view is a good one to especially to look at the septal leaflet. You can see that there's some interaction here with the septal leaflet. And you start thinking about using 3D in-face views so you can get a sense of where the leaflets are and where the leads are in relation to them. And the more I look at all of these images, the more I'm convinced that these in-face views are the best way to identify problems. Here you see a lead that is definitely impinging the septal leaflet and correlated to an eccentric jet of TR. And there actually have been some studies where, or at least one study where leads have been TE guided to try to guide them to these commissures. It's tough to guide them to the middle, but if you can push it into a commissure, you might be better off, although I'm not exactly sure. We use a lot of intracardiac echo in our lab for ablation, for lead extraction. So we have spent the better part of the last decade looking at the tricuspid valve and leads, particularly during extraction procedures. And you could see some scary stuff, including subvalvular adhesions. You could see this little pap muscle here is certainly adhered to this lead. Whether this is going to come out safely, I don't know. When you pull on the lead, sometimes you unmask these leaflet adhesions that you didn't see during static imaging. Here's a lead that I'm pretty sure is through the leaflet as we're pulling on it. Here, a lead is adhered to a tiny little papillary muscle that is holding on for its life to the inferior wall. And this lead is actually attached to the moderator band, which is not a problem, except that the moderator band typically has papillary muscles adjacent to it. So these all increase the risk during lead extraction. And there's no doubt that ICE is the best way to look at these leads, at least in terms of proximity, right next to them. But the 3D nature of TEE tends to be a bit of an equalizer. And of course, ICE is invasive. When you see a lead that is impinging on the leaflet, it becomes pretty obvious. This is a very old lead in a patient with left-sided heart failure, so probably also right-sided heart failure as well. But you can see that the posterior leaflet is being impinged, and the patient has severe or torrential TR that is maybe not even eccentric anymore, because I think there's multiple components of this jet, but the annulus has just dilated too much. And the jet is in fact tracking the lead, but he probably has bigger problems than just the lead. So removing this very old lead is very unlikely to do anything. And you have to be careful when you're identifying adhesions And because sometimes it can be subtle. And this patient who we're extracting because of an occlusion of the SVC and patient needs to be upgraded, I really thought that this lead was attached here to the posterior leaflet. It's thickened. There doesn't seem to be any independent movement. And you have a decent amount of TR with a big vena contracta that's tracking the lead. But if you zoom in, you can in fact see that there is independent movement of this lead. So it could be adhered, or at least resting on the leaflet, and it could be causing a little bit of TR, and it might be, but it's not adhered to it, and that's important to know if you're going to remove the lead. Here you see we're pulling on the lead during the extraction portion, and you're not pulling at all on this leaflet. So that's a good thing to know or to see during these procedures. In patients who have a temporal relationship of increased TR and lead placement and have an eccentric jet like this patient, you want to get to them earlier. Here you see there's an eccentric jet, and this patient developed TR within a year of the lead. So it's clearly the lead. You can see that the lead is restricting the posterior leaflet. Echo is very powerful to see these restrictions. And in this view, you can see that this leaflet is also being restricted, and there's quite a bit of TR. So this was under a year. It was a no-brainer to take it out. We pulled the lead out very easily. There was nothing dramatic to be seen there. And then what you want to do when you put the new lead in is prolapse it in. So you can see it's been prolapsed up the RVOT. Now you'll notice that the patient still has severe TR. And when the lead is finally placed, we made sure that the lead is going through the middle of the valve. But again, severe eccentric TR, but when the patient follows up, the TR is gone. So this is a lesson that we learned early on, that it does take some time for this leaflet to regain its mobility, and don't think that you failed when the TR doesn't get better. And I think the longer the lead's in there, if there's no acute damage to the leaflet when you're pulling it out, you got to give that patient months to maybe even a year to see significant improvement, because it's got to regain its flexibility. Some adhesions to the tricuspid valve are somewhat hidden. This is a patient who is undergoing lead extraction. There didn't seem to be any adhesions at all to this valve. But again, you can't see the septal leaflet in 2D, and that's the one that's usually adhered. But when you start pulling on the lead, you start seeing that you're pulling stuff, probably subvalvular stuff. It's definitely connected. And this is why I like prolapsing. Prolapsing might not increase your acute TR, but I think if you undermine these cords, then you have a higher risk of TR when you pull them out. Now, whenever you're dealing with these subtricuspid valve adhesions, you really want to laze through them. You don't want to just pull. And we typically end up with this little cast that remains where the lead is going through. And hopefully there's no increase in TR. This isn't associated with any TR. It just has some mild TR through the middle of the annulus. When there is a lead that's attached to the leaflet, that becomes what we call a vulnerable leaflet. So here you see doesn't seem to be any adherence, but whenever you see thickening and brightness on a lead near the valve, that should be a warning sign that it probably is attached to something. And here you can see it's a basal lead, somewhat basal, and there's thickening and echogenicity here. That's never a good sign. And there is severe TR. Now, whether this is due to lead, I'm not sure. It's central. The annulus is dilated. I can't tell if it started with the lead, but clearly there's a patient with a annular dilatation. When we start pulling on the lead, right here, you can see that now we're pulling this leaflet. The septal leaflet emerges as something that we're pulling, and this becomes vulnerable. You really want to make sure that you use some kind of power through this leaflet with the smallest sheath that you can in order to dissect it free from this area, and there's no more TR. But this patient's not going to get better with just this, because the annulus is just too dilated. Sometimes it doesn't work out that well. This patient, again, was having a lead extraction. It didn't look like there was any adhesions at all, but again, you can't see the septal leaflet. There's a little bit of thickening. And when you start pulling, you see the video that I hate to see the most during lead extraction, where you're pulling the septal leaflet. Despite using tools through that, we ended up with a flail leaflet. And this is a bit of a disaster for these patients. They always have severe torrential TR after this. And hopefully the percutaneous era that is upon us now will help us treat these patients without surgery. But lately, over the past few years, in elective cases, when we see this, we seriously consider aborting the procedure. And one more case where we saw a lead that was directly on the papillary muscle. This lead was only in for a year, but we saw that when we pulled, we were almost plucking this papillary muscle off of the inferior wall, and the patient had no TR. So we actually sent the patient for surgery, and the lead was in fact attached to the pap, and the surgeon couldn't even remove the lead with his hands, and it actually broke the lead, and a little remnant stays there. But the patient, of course, doesn't have any TR, and he had an epicardial system placed. Whether 3D ICE can be helpful, we're not sure yet. We've been experimenting with a little bit. The images are quite beautiful, but they're delayed. The processing isn't as good, and we just don't have enough experience yet to know if this is going to help. But I'm certain it will. And of course, you can get that surgeon's view or end-face view of the valve, which is very, very helpful in these cases. Patients with TR lead-related TR tend to represent about 5% of the patients that are referred for lead extraction. And the TR does get better in about a third of these patients. But in a select group of patients, if you have an acute problem with the leaflet, you can make them worse. And there are a couple of associated factors that can lead to lead-related TR, and that's loops, as we discussed, female gender, things that have been associated with this New York class, and things that lead to right-sided heart failure. But you do want to get them out if you can, because the data would suggest that if you can remove the lead, if it's causing TR, and the TR gets better, that you have a better chance of survival. So it's a complicated question, complicated procedure, but you do want to remove if you can. Here's a case that we just did yesterday, but I wanted to show it because it was so interesting. This is just 2 leads, one old ICD lead and one new ICD lead, complete obstruction. We couldn't get through, patient needed an upgrade. So the question is, which one is the 18-year-old 6949? Which one is the 6-year-old 6935? This one is thickened. It's completely attached to the posterior leaflet. There's no independent movement whatsoever. And this one is straight down the middle of the annulus. There's really no thickening, at least at the valve level. And we have to remove one of them. So which one is which, and which do you want to take out? So actually, this one is the new one. So perhaps this wasn't prolapsed in. And I was very glad to see that, because then I can remove the old Fidelis without risk to the tricuspid valve. You can see again, the old lead is stuck on the posterior leaflet, and the new lead is straight down the middle. Now, this wasn't causing significant TR, but it might in the future. The jet is kind of central, but we'll leave that battle for another day. And I certainly was glad that we were able to take out the old Fidelis rather than the new one that was stuck. So here's the lead moving. We're pulling on the middle lead, and you can see it's not pulling any leaflets with it. And eventually it came out very nicely. So a proposed clinical algorithm, although there are some caveats here and just subtle. If you suspect the lead is causing TR, get a good 2D, 3D echo where someone is really able to look at the mechanics. If the patient has a dilated annulus, RV failure, severe pulmonary artery fractures, it really should be managed medically at first, because removing the lead is not going to do much. If they don't have right-sided failure, get a TE or an ICE study. TE usually is what we choose. And if the lead is not interfering with the leaflet and they have a correctable left-sided cardiac function, then the patient just needs medical management. Hopefully they improve. Now, if the patient does have a correctable left-sided cardiac dysfunction, and they're going to go for surgery, then of course you should do a tricuspid valve ring at that time. If the lead is interfering with the leaflet and the RV is dilated, then they should have the ring becomes the primary solution for this patient. And at the time of surgery, they should have their lead removed. If the RV is not dilated and the lead is interfering, that's the group of patients who might benefit from TLE, plus minus TBR, maybe even percutaneous. So this might change. This schema might change with the era of percutaneous tricuspid valve replacements. But as of right now, this seems to be the sweet spot of the patients that we might be able to help. So in summary, what things that support lead-related TR? Is there a temporal relationship between the procedure and the emergence or worsening of TR? Is there independent lead, no independent lead movement, an eccentric TR jet, echo-based identification of lead impingement, and a normal annular size. Female increased pulmonary artery pressures and IV dilatation have been associated with this. Things that do not support lead-related TR, no temporal relationship to the procedure, independent lead movement, symmetrical TR jet, and annular dilatation above 4 centimeters. And of course, multifactorial etiologies are extremely common. And with that, I will stop. Thank you very much.
Rob, very much.
Yeah, don't go away, there'll be lots of questions.
Thanks, Rob, very much for joining us. It's Jamie Manluku, part of the panel here. So in a very high volume center with a lot of expertise like yourself, how many of these are you doing per year? I know there's tons of infection and lead failures, but what proportion of your practice is actually targeting tricuspid regurgitation from new or chronic implants?
The answer is almost never. There are definitely cases within a year, a handful, maybe 2 or 3 a year, where we take the lead out because we think it's abruptly or acutely causing TR. That's not really a lead extraction procedure, and that's easy. When we are referred a ton of cases, is the lead causing this severe TR that was just noticed? And we usually get a TEE, and the lead's usually accused of causing the TR, and whether there's impingement or not, usually the horse is out of the barn at that point. These are usually chronic leads. The patient has simultaneously developed tricuspid valvular annular dilatation, and the amount of TR is now multifactorial. Sometimes they have left-sided problems as well. And what we tell them is that removing this lead at this point will just introduce risk, and it won't necessarily do anything for the lead. And we could actually, for the TR, we could actually make it worse. So we look for other things to help. Does the patient need surgery for any correctable left-sided problem where they could put a ring in at that time and remove the lead? Would the patient benefit from cardiac resynchronization therapy? That's a possibility. Or the emerging question that's coming now is, can we take the leads out knowing that the TR probably won't get better, but at the same time, a percutaneous stented valve would go in, and that would do 2 things. That would, 1, remove the lead, and 2, avoid the lead from being jailed by the percutaneous valve, which is another huge subject in and amongst itself. So the short answer to your question is almost never.
That's a great presentation. I have 2 questions. Have you noticed a higher proportion of this in children who get devices for congenital complete heart block? As they grow relatively, does it affect the valve more? And secondly, with conduction system pacing, are you noticing any difference in TR? Is it more or less? Is the septal leaflet affected more?
I haven't noticed any differences in pediatric population. Of course, they transfer their care to us when they get to age, and at that point, sometimes the leads are 20 years old. And while they're usually doing okay from a TR perspective, I do have a handful of cases where I pull those leads out, and the valve does appear to be vulnerable. I do think it has more to do with implantation technique and the lead being not prolapsed in, the lead being relatively basal and interacting more with the stuff under the tricuspid valve, cords and papillary muscles. I think it's always safer to put these leads on the apical septum. But again, they don't have coils, which tend to be a little bit more sticky in terms of endocardial surfaces and valves. So I don't think there's a bigger percentage of kids who have this problem, but I can't be sure. In terms of conduction system pacing, I don't think we know the answer to that yet. When a lead is in a His position, it almost never causes TR because usually it's not even in the ventricle. And when it is in the annulus, it's by definition in between the valves. Whether left bundle pacing is going to lead to TR, again, you won't increase your rate of, you'll pretty much abolish your rate pacing-induced cardiomyopathy, so you won't get that. So actually, it's a bit of a more pure example of lead-related TR. If you spear the septal leaflet and push it against the wall, of course, that's going to cause TR, but I've never seen that. And in our experience, if you put it in the right position and leave ample slack, I have yet to see TR. Now, maybe it's just a probabilistic thing, but my bet is that with these tiny leads coming off of the septum, there'll probably be slightly less lead-related TR, but will it go away completely? No, it's impossible.
So that's a great algorithm that you showed towards the end. Thanks very much. When I looked at it, it looks like a fair number of patients are excluded, not on the basis of procedural futility, but clinical futility. And your subsequent words, there was a fair amount of gloominess as well about, are we really able to improve their clinical outcome because it's a mess. So do you have any guidance about which patients we should be intervening on much earlier to prevent things from deteriorating? How are we going to screen for them?
Time is of the essence, that's for sure. So maybe you should routinely evaluate patients for tricuspid regurgitation shortly after lead implantation to avoid this mess to begin with. But in general, if there's a temporal relationship, even if you can track it down from years ago, and I was surprised by how well echo can identify these lead impingements. If you see that, and there's a temporal relationship, an eccentric jet, and the annulus isn't terribly dilated, I think it's reasonable to take these out, but you have to give them a little bit of time. Now, I am a little bit worried about these patients because if you leave them for too long, and I don't know how long that is, they do increase their right-sided pressures. And this is a similar problem with percutaneous tricuspid valve replacement. What's going to happen with patients who have very high pulmonary arterial pressures and then suddenly you give them a functioning tricuspid valve? They're probably not going to do that well either. So I think the earlier you can, a normal annular dimension and echocardiographic evidence, you should be relatively aggressive with these patients because it's only going to get worse.
So would you advocate, a routine echo, maybe 3 months after implant on RV leads and left bundle area leads, regardless of clinical findings?
Specifically left bundle leads, I don't have any, I'm unaware of any data that says that conduction system leads are going to result in more TR. I haven't noticed it in our patients, and we haven't done anything systematically, but whenever the paradigm is shifting and we're all rapidly moving to a different pacing strategy, I think you should be conservative, and protocols like the one that you just suggested seem smart to me.
Okay.
Questions from the audience?
Rob, I don't know if you're seeing this, but patients with RV pacing, very bad RV dilatation, functional TR, but normal LV function. Are you upgrading those patients to CRT?
So it's a patient with a normal, the only problem they have is increasing TR?
Functional TR, the lead's not impinging, the tricuspid annulus is dilating, and this is through RV apical pacing, but the LV function is normal. We've got a couple.
And there's no increase in mitral regurgitation?
No increase in say mild to moderate mitral regurgitation, severe TR.
So they're feeling the effects of RV pacing for sure. In my experience, usually the MR precedes the TR or is out of proportion to the TR. As long as the lead isn't impinging. Maybe you just haven't noticed that the lead is impinging. But yes, these patients fall into a subset of patients who have heart failure with a relatively normal ejection fraction or mildly reduced ejection fraction from pacing or from a left bundle branch block or severe valvulopathy. And if there's no other reason, such as atrial fibrillation that we could intervene on, then we absolutely are being aggressive in these patients to upgrade them. Yeah.